Thank you, Dr. Keshav. It's indeed a privilege to introduce Dr. Sanjay Sinha to all the viewers, though he doesn't need any formal introduction. He's a consultant urologist and a transplant surgeon with a specific interest in female urology, urodynamics, neurogenic bladder, and renal transplantation. He's a graduate and postgraduate from Institute of Medical Sciences, Banaras Hindu University, and where he had a first rank at the university with 8 distinction and the best student award. He did his MCH from SGPGI Lucknow in 1995. And briefly, he visited Long Island Jewish Medical Center, New York in 2000, and later Royal Melbourne Hospital in Australia in 2005 in the field of functional urology. He has the largest experience in the stress incontinence surgery in the state as well as in the country. Largest number of neurogenic bladder patients under his follow-up. Conducted many workshops in the state, in the zone, as well as the national level, and internationally, including Brisbane, Kuala Lumpur, and Johannesburg. He is in the leadership position in the editorial board of many journals, including International Urogynecology, Indian Journal of Urology, Current Bladder Dysfunction, and is the chairman of the Bladder Cancer Guidelines for Urology Society of India and convener of the guidelines on incontinence and Luts under the aegis of Urology Society of India. He has also got a Best Reviewer Award by Indian Journal of Urology in 2011 and has the busiest urodynamics department at his center. He's currently the convener of Female Function Urology subsection of Urology Society of India. And today we are very fortunate to have you for this webinar on urodynamics, which is for residents' point of view, a little underrated. But what you have to understand is what is a stethoscope and echo for heart is the same way the UDS is for the bladder. A very, very important topic. You get this question in your theory, you get a UDS tracing in your practical exam, but it is not only from the examination point of view, but from the clinical practice also is important. You should not be looking like an orthopedician reading an ECG and fails to find anything. It should not be like that. So his talk will be very relevant today, touching the very basic part, and thereon he will take towards the normal interpretation to the artifacts and the various interpretations in the urological conditions with Luts. And with this, I'll invite Dr. Sanjay Sinha. And before that, I'll just say the link for the quiz will open at 8:15. There'll be few residents who have opted. They will stay unmuted with their video on. Dr. Suraj, Dr. Saurav, Dr. Vivek, anybody who wants to join for the brief interaction in between when Dr. Sanjay Sinha is delivering his lecture, please put your name on the chat box. With this, over to you, Dr. Sanjay.
Thank you so much, Dr. Arun, for those kind words. A slightly dated introduction, but thanks all the same. Thank you, Rajiv and Keshav, for giving me this opportunity. And it's always a pleasure to speak to the residents. Let me share my screen. Right. Urodynamics should not be regarded as, I hope you can see my slide.
We can see
my slide? Yeah, can somebody confirm? Yeah, okay. Right. So urodynamics should not be regarded as a test. It's what I call a 3-step consultation. It's you see the patient, you understand the patient's problem, you try and decide what is the question you want to answer. Then you do the urodynamic investigation, try and answer the question, and then reassess your patient in the light of what you found and all the other information that you had from before to draw conclusions about what the person's problems might be. Essentially, in this program, this is what we are going to do. I'm going to talk about the components of a normal study. How do you do quality checks to understand whether the tracing that you have is a good quality trace? How do you spot common artifacts? And then practically, how do you interpret urodynamics for female lower tract symptoms, for male lower tract symptoms, and for neurogenic lower urinary tract dysfunction? So sorry for that. For neurogenic lower urinary tract dysfunction. So let's start with the first section, which is the underlying principles, quality control, and artifacts. So what's the logic of urodynamics? So when we do a urodynamics study, we are essentially looking at measuring the detrusor pressure. That means the pressure that is contributed by the bladder. But we have no practical method of measuring the pressure contributed by the bladder. So what do? We need to measure the pressure from within the bladder, which reflects not just the bladder pressure, but also the abdominal pressure. And then the machine subtracts that digitally to yield the detrusor pressure. But we don't want to do this only once. We need to do this on an ongoing, continuous basis. And because we need a continuous measurement, hence we need a second channel into the bladder to fill the bladder up as we are doing this. So you fill the bladder with one channel, measure pressures from the bladder using a second channel, and have another catheter in the rectum typically to measure the abdominal pressure. And the machine subtracts these two to yield the detrusor pressure. And these are abbreviated by convention as P vesicle, P abdomen, and P det. So this is how the setup looks like. That's a P vesicle measurement channel. That's a P abdominal measurement channel. The P det, which is a subtracted, which is the one which we are really interested in.
Sanjay, slides are not moving.
They're not moving?
No. It's in the first slide.
We are on the first slide only. We are on the first slide.
Oops. Sharing. Oh, hold on. There is some issue. Okay, I'll just stop and restart. Just give me a moment. There must be some problem. Does it show the
setup?
Let's see whether it moves. Is it moving now?
Yeah, you go back, sir, first.
Okay.
Go back.
It's moving now?
No.
I'm not sure what's the issue. I'm getting a message, bring your shared window to the front, which is strange. I never had that message before. Okay, just give me a moment. Let me quit all the presentations and then reopen. Just a moment. Does it work now?
No, sir. You go back, sir, first, then we'll see.
Can you see the agenda slide now?
Yeah, I am on now the agenda.
Okay. Section 1.
Now, okay. Section 1. Fine, fine.
It's running?
Yes.
The logic of urodynamics?
Yes, yes, absolutely.
Okay. I'm sorry for that glitch. Okay. So I'll just very briefly rerun this. So essentially, we are looking at the detrusor pressure, and that's generated by subtracting the abdominal pressure from the vesicle pressure. And since you want to do this on a continuous basis, you need to have a second channel in the bladder to fill the bladder continuously as you measure the pressures. That's the setup. And in case any of you find that you're not seeing my slide, please raise your hand or just prompt or call me out. So that's the P vesicle channel, the P abdomen channel, the subtracted P det channel. And then you need to fill the bladder at a rate which is typically more than the usual rate, because if you fill at a physiological rate, it will take morning till evening to do one study. So we usually fill at rates substantially higher than the physiological rate, typically at 10% of the expected bladder capacity or thereabouts, expressed as milliliter per minute. And you can use either 2 single channel tubes, typically infant feeding tubes, or a double lumen catheter. And if the patient has a lesion above T6 in the spine, this is for the neurogenic patient, you must monitor the blood pressure, because such patients might develop autonomic dysreflexia when you do the test, and that can be a life-threatening emergency. Right. So let's take a look at a typical urodynamic trace. Now on the top in the blue is P vesicle. The second line in red is the rectal pressure channel, that's P abdomen. And the third is the subtracted pressure line, P det. This is the flow channel, the voided volume, the volume filled, and the EMG. And this is the time axis. And you can see volume filled here on the time axis. So this is the filling cystometry phase. That's your mix, the voiding part. That's the voiding pressure flow. Oops, wait, I'm losing some of my, okay, right. You can see the sphincteric activity. It typically increases as the bladder is filled up, and this is called a guarding reflex, but the EMG is not a very reliable method of measuring these pelvic floor activities and these sphincteric activities. So it doesn't always reflect this very well. That's the point at which the patient has been told to pass urine, and you can see the sphincter becomes silent. And the silence typically happens before the onset of the detrusor contraction. So the outlet relaxes just a fraction of a second before the detrusor contraction happens. And you can see that there's, when you look at the EMG, you're actually looking at change in EMG activity here rather than the absolute values of the EMG activity. So this is the urodynamics matrix of when we do a study. Now, let's look at these aspects. We are going to look at the fact that urodynamics is interactive. You need to talk to the patient while you do it. You want to duplicate the patient's symptoms and be careful with incidental findings. And we'll come to that in a moment, that you can sometimes get findings like a phasic contraction when you're filling the bladder, which might not be relevant. So you need to be careful. You always interpret in real time. And if you're not there, then you must have some surrogate who is capable of interpreting in real time. Because if you don't do that, sometimes it's just not possible to understand what happened at the time of the test. Sometimes asymptomatic findings might be important. For instance, in neurogenic patients, typically there are often no symptoms at all, but the findings might be crucial. And you need to at least decide what the report is going to be before the patient leaves the suite, because otherwise you need to get the patient back on the couch, recatheterize the patient if you want to do something else, which is very uncomfortable for the patient. So as I said, urodynamics remains a three-step consultation process. So let's go back to this trace and see what are the basics here. So the transducers should be zeroed to the atmosphere. So never zero the transducers to the patient, you zero to the atmosphere. And you can see when you zero to the atmosphere, there is a baseline resting pressure in the abdomen. And that varies depending on the position in which this patient is and the body morphology of the patient. These values that you see here are a good method to see whether the test you have done is likely to be a plausible test or not. So if you get values which are wildly outside this range, it would suggest that there's some problem somewhere in the way you have done your zeroing or the level at which you've kept your transducers and so on. The initial PDET could be somewhere between 0 and 6. You would ordinarily expect it to be 0, but it's not always precisely 0. And you ask the patient to cough typically once in a minute because you want to see whether the transducers are working well. And if they're working well, you should see a good subtraction of the cough spike. So the cough spike pressure is transmitted both to the bladder as well as through the abdomen. And they should subtract out because that's not contributed by the detrusor muscle. So you should find that on the PDET channel, there is very minimal or a little spike or a biphasic kind of a spike on the PDET channel. The fine trace should match. So this is a good method to look for quality control. So you can see the small movements in the tracing, which can happen when the patient moves or speaks or even breathes. All those things should be matching on the two channels. And that tells you that the transducers are recording well. The micturition command should be recorded either electronically, as it's done here by a micturition command, or you can draw a line and tell that this is the point at which the micturition command was given. These are all methods by which you can do your good quality control to tell that the patient that you have a valid test. And these resting pressures that I just told you are not very well standardized in children. We are actually in the process right now of a multicentric study in which we are doing the standardization process. The changes are typically steady in the PDET line because detrusor is a smooth muscle. Smooth muscles cannot contract and relax suddenly. So whatever changes you get in the PDET line, they should be smooth changes. If you get very sharp changes, they've got to be some sort of an artifact induced by a skeletal muscle, cannot be from a smooth muscle. So what are the common artifacts that you can come across? Well, artifact is something that's not naturally present, but occurs as a result of whatever procedure you've done. Some of these may be non-critical and may permit a reinterpretation. So once in a while, for instance, let's say when the patient is voiding halfway through the void, the rectal channel drops out. You can go back to the P-vesical channel. And often if you've had some part of the abdominal channel recording done, you may still be able to interpret this study, but some may be critical. So if you have a critical flaw and you don't identify it, completely invalidates the study. It's like what they call garbage in, garbage out. So if you have not really identified a critical flaw at the start of a study, you cannot interpret the study at all. And you have no option but to go back and do the whole thing again. So I don't know, Arun, who is there for me to ask a question from?
Suraj is there.
Okay. Suraj, you can unmute yourself. What's the problem on this particular trace, Suraj? Are you there?
Yes, sir. I didn't hear your question.
So what is the problem on this trace?
So the period spikes are noted and P-vesical pressures are increasing, but the abdominal pressure is not being reflected.
Right. So as Suraj rightly pointed out, the abdominal channel is not recording. So when you do this initial cough, you find that the cough is completely seen on the PDET when it should not, because it's not something generated by the Detrusor wall, because there is no recording on the P-abdomen channel. So in this patient, the fine pattern you can see is not matching. So you can see here, this is a fatal flaw. So if you have this kind of thing happening, you just cannot interpret the study later. The cuff spikes are not noted in the abdominal pressure channel. The fine pattern is not matching. You need to recheck the rectal catheter, flush, check the connections and start again. Now, sometimes in the beginning of your study, this might happen from the P-vesical channel. Sometimes when the bladder is empty, occasionally the tip of the catheter touches the wall of the bladder and doesn't record well. But the moment you start filling a few ml into the bladder and it starts recording faithfully. So that can happen once in a while and that should be fine. It usually is not a problem. Okay. This one, who's going to answer what's happened here?
Vivek is there, sir.
Vivek, what are we seeing on the PDET channel?
PDET, there is initial rise and then there is a flat line, sir.
So is that valid? Is that a valid rise that you're seeing in PDET?
No, sir. If P-vesical is not raised, so
right, correct.
So PDET should not rise.
Right. So as Vivek very rightly pointed out, you cannot get a valid change in PDET without a corresponding change in the P-vesical channel. So whenever you see any pressure changes on PDET, your eye should automatically go to the P-vesical channel to see whether you find a corresponding change there. And if you don't, that tells you that whatever you're seeing is because of changes in the abdominal pressure, and that has to be an artifact. Right, good. Okay, so that could happen for a variety of reasons, like for instance, let's say an air bubble in the channel and so on. Okay, so this is the patient in whom you can see, for instance, the channel, the vesical catheter has been removed. So there are some situations where we may want to remove the catheter for certain reasons, and you will see that in a test subsequently when you're doing a stress test, for instance. And when that happens, then obviously the PDET channel recordings will go away completely. Okay. So this can happen because you've deliberately done it, in which case it's not an artifact, or it can happen because it's slipped out, in which case it's an artifact. So if it has slipped out, this would be an artifact, and you get a sudden drop to zero. That's typically because the catheter has come out of the bladder. The other thing that can happen is you can have a change in posture. Now, who's going to answer a question on this one? Arun?
So both are there. So Suraj is there, Vivek is there, Saurabh is there.
Suraj. So when the patient changes his or her posture, let's say we make the patient stand up. A woman has come with stress incontinence. You make her stand up and want to see whether she has stress incontinence or not. When she stands, you find that there's a change in the abdominal pressure channel. Why does this happen? And what step should we be taking when we are changing the position of the patient?
When the patient changes the position, then there will be abdominal muscles acting over it. So when the abdominal muscles are acting, you have to see that is reflected on the P-vesical pressure rather with the total pressure equally rather than the detrusor pressure acting at the same time.
What step should you take when you make the patient stand?
Make sure the catheter, rectal catheter doesn't come out.
Okay. Anything else?
And
so the transducers have to be at the height of the upper border of the pubic symphysis. When the patient stands up, then the height of the patient goes above the bladder actually goes well above the height of the transducer, right? So this rise in pressure that you're seeing on the P-abdomen channel here, this is part of a stress test incidentally. And this woman has been asked to stand up. She's not leaked in the sitting position with her catheters in place. So the vesical catheter has been removed. And finally, the patient has been asked to stand up. Now, when the patient stands up, as you rightly mentioned, there is a change in the intra-abdominal pressure because the abdominal pressure when you stand is higher than the abdominal pressure when you sit. But not all of this change may be because of that. Some of this can be if you have not adjusted the height of your transducer. So you must readjust the height of the transducer before you actually start recording. Otherwise, you will over-record the leak point pressures. So when the patient stands up, readjust the height of the pressure transducers back to the superior border of the pubic symphysis. Okay, now take a look at this trace, and you can see here on the P-dead channel, after the patient has passed urine. So this part here is storage from here to here. This part is voiding. During storage, there's a low pressure, which is what you expect. When the patient starts passing urine, there's a bladder contraction, which is volitional after the micturition command. That's the void of the patient. The patient has passed urine here. The bladder empties, but you see a high pressure contraction after the bladder has emptied. Now, this high pressure contraction after the bladder has emptied is called an after contraction or a post-voiding detrusor contraction in the current terminology of the ICS. This after contraction is not a very well-defined entity, but you need to differentiate this from bladder outlet obstruction, because you could have somebody in whom the pressure goes very high and the patient doesn't seem to be passing urine if the patient is obstructed. Well, the way to differentiate it is that in this after contraction, the bladder has already emptied. So you can see the patient has already passed urine, and then there is a further rise in pressure beyond where the pressures were originally at the end of micturition, despite the bladder being empty. So that's an after contraction. Now, if this patient had half emptied the bladder and you found this, then that's not an after contraction. But with the bladder nearly empty, and there is no consensus on how much can remain to say that it's nearly empty. But if the bladder is nearly empty, like in this patient, then this is an after contraction, which is not really of clinical significance. So this is not the maximum detrusor pressure. The maximum detrusor pressure is here, not here. So sometimes machines may get fooled by this. Okay, Suraj, tell me two artifacts in this.
So the detrusor pressures are rising, which is not reflected on the P-vesical pressure.
Right.
The bigger fat arrow, and the linear arrow shows
yeah, you're right. So essentially you can see here that these so-called phasic contractions are not really phasic contractions at all. They're all because of changes in because of spontaneous rectal activity. And the arrow here, which you have, this is showing that the pressure is going up, but this is not really a poorly compliant bladder. That's a term I'll define in a moment. This is happening because there's a pressure drift on the abdominal channel. You can see the pressure dropping gradually. So overall, the pressure in the abdominal channel has been dropping. And you can see that the vesical channel is holding steady. You can see the vesical channel at this point as well as at this point is more or less the same. But the pressure seems to be going up mostly because of a drop in the abdominal pressure channel. So spontaneous rectal activity, that's not detrusor overactivity. And there's a pressure trend because of drifting down of the abdominal pressure, which is contributing to what appears to be a poorly compliant bladder. And a last slide on artifacts. You can see here sometimes when you fill the bladder too fast, you can induce what appears to be a very poor compliance. Now, this patient's bladder is poorly compliant, but it's appearing to be much lesser compliant than it actually is because we have filled very fast. And how do we know that? The moment you stop filling, the pressure starts coming down immediately. That tells you that the bladder has not been able to accommodate when you're filling the bladder too fast. And the proof of that is that when you restart filling, and you can see a little bit of filling done again here, the moment you restart, the pressure rapidly rises again. And the moment you stop, it drops again. So this is not a phasic contraction. And although this patient does have poor compliance, that means less elasticity of the bladder wall, it seems to be much poorer than it actually is because we have filled too fast. Right. So let's now go to the key basic findings. So some of the findings I ended up inadvertently telling you about when I was showing you the artifacts. But the key findings are in abnormal storage, we are looking at detrusor overactivity and poor compliance. And in abnormal voiding, we are looking at bladder outlet obstruction and underactivity. And let's look at these terms a little bit more. So during storage, we expect a normal bladder to have a low pressure. So it's like a soft balloon into which you are filling air. So when you fill air into a soft balloon, it expands without much rise in pressure. So the pressure remains flat. Now, if it does not remain flat, it could take one of two forms. You could either get a phasic rise and fall, which you call detrusor overactivity, or you could have a progressive rise in pressure, which you call poor compliance. During voiding, typically, if you don't have normal voiding, the two common problems which you can face are bladder outlet obstruction or an underactive detrusor. And to understand these two terms better, if I'm in a room and I'm trying to exit the room by opening the door, if I need to push very hard, and yet if the door opens very slowly, that implies that the door is jammed, and that's what outlet obstruction is. So you record a high pressure in the bladder with a slow flow. And if you find that the bladder pressure is very low and the urine has come out very slowly, or the door has opened very slowly, to go back to the same example, it's an underactive detrusor. But what you must keep in mind is that you, especially women, for instance, can void with apparently no detrusor contraction at all, or a very minimal contraction. And if they have passed with a normal flow, and by normal flow, I mean a normal pattern, normal rate, have no voiding symptoms, then this might imply that the outlet resistance is very low, and hence, the moment they relax their outlet, they're just able to pass with a high speed. And that doesn't mean that the bladder is weak. It's just that the outlet resistance is low. So there are several other things we look at. I'm not going to go into all of these because that will take too much of time. We need to focus on the important things. We'll primarily focus on these four conditions. So the first key finding, detrusor overactivity. During storage, we just said that the pressure should ordinarily be low. Here you can see on the PDET channel, which is a subtraction channel, you have phasic rises and falls, and that's detrusor overactivity. This patient also has early sensations, which is common. Those are the phasic contractions. And on the flow channel, you can see small trickle of urine happening. So this patient has detrusor overactivity incontinence. So that is our first key finding. The second key finding is poor compliance. And you can see here on the PDET channel again, a progressive rise in pressure as the bladder is filled up. This is like a balloon which has a stiff wall. So a thick-walled, stiff balloon, when filled, when you try to blow air into it, you really need to blow hard. This bladder is like a stiff balloon and has a poor compliance. The pressure rises as we fill. Compliance calculations could be done at any 2 points in this curve, but by convention, usually we take the 2 points as the end fill and the beginning of filling as the 2 points. And we take the difference in the volume and the pressures for both of these. And we express compliance as milliliters per centimeter of water. What's normal is not very well defined, but typically the normal compliance is very high. So it could be 40, 50, 60 milliliters per centimeter of water, at least 20. Most studies take the abnormal as either less than 10 or less than 20. But you must also check the absolute values of the pressures, because that needs to be combined with the information from the compliance to really draw good conclusions. So you could have high end fill pressures or uncomfortable high pressures with the compliance, which is apparently okay, and vice versa. So you need to look at both things. Look at the compliance, look at the end fill pressures. That will give you a clue as to whether the bladder is likely to be safe or unsafe. The third key finding is bladder outlet obstruction. Now you can see here a patient, again, go back to the third trace, and that's the PDET channel. That's storage, and you can see storage is reasonably okay, some low pressure phasic contractions. But when this patient voids, there's a very high pressure. And right now I'm not going into numbers, just wanted to take a look at the pattern of the trace. Very high pressures, very slow flow, consistent with bladder outlet obstruction. And we are not getting right now into the reasons for why this has happened. Now, remember, you need to be able to see that there is a permission to void given here. Because if there is no permission to void given here, this could well be a phasic contraction with Detrusor overactivity incontinence. The fact that the patient was given permission to void here and then produced this contraction, and in the opinion of the investigator who was on site, this was a volitional void. This is a volitional void with bladder outlet obstruction. But in a different situation, the same trace could just be a terminal phasic contraction with incontinence. And the last key finding is an underactive detrusor. Again, go back to the PDET channel. That's storage, which is reasonably okay. You filled 320 ml with an end fill pressure of 15, acceptable compliance. But when this patient passes urine, you find that the bladder pressures are low and the flow rate is very slow. Now you can see some spikes here. And these spikes, as we just discussed in the beginning, you do not get rapid changes in any smooth muscle. All of you who've done, when you've seen a laparotomy or a laparoscopy, and you've seen the movements of the intestine, you find that the contraction, a peristaltic wave, proceeds slowly across the bowel. Similarly, the detrusor muscle is a smooth muscle. The contractions of the detrusor muscle cannot happen suddenly. So any sudden changes in PDET channel have to come from a skeletal muscle, and here it's coming from the abdominal strain. So this patient is straining with abdomen. The abdomen is a skeletal muscle, set of skeletal muscles. And that subtraction artifact here is looking as spikes in the PDET. So those spikes are not the actual contraction pressure. You need to go below all those to be able to see where the pressure lies. And this is a very weak detrusor contraction. So another couple of key pressure flow parameters, there are two terms which you will often come across. The maximum detrusor pressure, abbreviated as PDET max, is the maximum value of pressure that you record. But most of the data by which we look at whether a patient is obstructed or not obstructed is not by this. It's actually by the detrusor pressure at maximum flow. And these are two different terms to imply two different things. The maximum detrusor pressure is the absolute maximum pressure that you recorded on the PDET channel. But the detrusor pressure at maximum flow is the pressure at the time of the maximum flow. So the maximum flow here in this patient is around this point, and that's the PDET Qmax, not this. Now, in this particular patient may not make too much of a difference, but there can be many other situations where it may make a huge difference between which of these two pressures you feed into your calculations to decide whether a patient is obstructed. And you can see straight away that if a patient has an after contraction, you may record the maximum detrusor pressure. The maximum detrusor pressure will be way higher than the detrusor pressure at maximum flow. As I said, you need to be able to observe and see what the patient is doing to understand what has happened. Just like when this child is standing next to this dog and passing urine by the side of the road, is he passing there because he's got an overactive bladder, the stress of an impending exam, in response to this Nike ad, his comradeship with his canine friends standing beside him, or is it just normal social behavior? The only way to understand all this is to talk to the patient to understand what happened. So let's go to the next section, which is urodynamics for lower tract symptoms in women. And we look at OAB, urgency incontinence, stress incontinence, and voiding dysfunction. Now, urodynamics for OAB and urgency incontinence might be required in some settings prior to more invasive management, in patients with treatment failure, with associated voiding difficulty or elevated residuals, patients who develop upper tract changes, or in whom you have a suspicion of neurogenic dysfunction. Urodynamics for patients with stress incontinence, sometimes for obtaining a diagnosis, although classically you don't really need UDS to obtain a diagnosis of stress incontinence, to define the type of stress incontinence, to predict the success of what you're going to do by looking at presence or absence of ISD, to predict the complications of your procedure by looking at whether the patient is more likely to have urgency incontinence post-operatively avoiding dysfunction, and to examine patients who have recurrent stress incontinence to see whether it's because of residual or recurrent stress incontinence, detrusor overactivity, whether they have ISD, and how's the bladder contractility, all of which may influence what you're going to do next. So when you look at the urodynamics findings in women with urinary incontinence, these are the things that you could find. You could find a patient who has Detrusor overactivity with or without incontinence. You might just find early sensations and urgency. This is especially common in patients who present with overactive bladder. Not all patients will show demonstrable changes in the pressure line. You might just find reduced compliance, usually in conjunction with another diagnosis, sometimes as a standalone finding. You might find urodynamic stress incontinence. You could find urodynamic mixed incontinence. You might find cough-associated Detrusor overactivity with incontinence. You may get a completely different alternate diagnosis like bladder outlet obstruction or neurogenic lower tract dysfunction. Or you might find a normal study, which does not, by the way, rule out a diagnosis of overactive bladder or urgency incontinence. So take a look at this particular patient. This patient has Detrusor overactivity. And a question for one of the residents, Arun.
Yes, sir, they are active, sir. Please ask.
Okay. What proportion of women will show Detrusor overactivity if you do a urodynamics, if they have overactive bladder? Vivek? Sorry, I've only got the two of your names, so you're in the firing line, Vivek and Suraj, unless I can get some more names. So what proportion of women will show Detrusor overactivity when they have urodynamics for refractory overactive bladder? Okay, so it's about 60% of women and about 90% of men will show Detrusor overactivity when you do urodynamics for refractory urgency incontinence. So when you have a patient, when you find Detrusor overactivity, there are certain ways in which you want to define what you are seeing. First is, of course, making a diagnosis that it's a phasic contraction. You could have terminal Detrusor overactivity at the end of filling at capacity. If the patient has a background of neurological problems, you would call it neurogenic Detrusor overactivity. You want to see the threshold filling at which this phasic contractions have started. You want to see the height of the phasic contractions. Is there any associated incontinence? Is it provoked, let's say, by rapid filling or by the sound of running water or by touching something cold? And then finally, is it representative of what the patient experiences in his or her day-to-day life? So these are all the questions you must answer when you find a patient in whom there is Detrusor overactivity during filling. Some additional terms which have been more recently defined by the ICS: high pressure Detrusor overactivity, which in the opinion of the investigator is perceived to be potentially dangerous, or a compound Detrusor contraction where the pressures do not come back to normal and keep rising again and again subsequently. The next important term to define is the abdominal leak point pressure. Now, the abdominal leak point pressure is the pressure at which you get urine leakage due to increases in intra-abdominal pressure in the absence of a Detrusor contraction. So you're trying to look for stress incontinence. You measure the pressure from the abdominal channel, and you are trying to see at what pressure in the abdomen does urine leak out of the urethra. And that pressure, the minimum pressure at which that happens, is the abdominal leak point pressure. Now, this is an older slide that I have deliberately used here. You can see here, I don't do it this way anymore, but still it's important to see that there are Valsalva maneuvers done here. So you can see a prolonged rise in pressure, and there are also cough maneuvers done here. And these two things yield two different types of pressures, and both yield different things. So Valsalva is more easy, is more reliable. You can do a Valsalva and you can give a more precise pressure. So you might be able to tell, okay, in a Valsalva leak point pressure is 86 centimeters of water. It's more difficult to do that with the cough spikes, because ultimately you need to take the height of this cough peak as the leak point pressure, because you can't really differentiate in this cough spike where the leak happened. So when you do graded coughs, you can see what's the least graded cough at which the patient leaked, and the height of that cough pressure is the leak point pressure. But with Valsalva, you can see the precise pressure at which it happened. But the thing is, women don't typically leak with a Valsalva. They'll tell you that we leak when we cough, move around and things like that, rather than with a Valsalva. So the Valsalva leak point pressure usually is not as representative for the patient as to regarding what's happening. And many women can't do a Valsalva. So it's difficult to actually get a Valsalva leak point pressure. About 10% of women will not leak with a urethral catheter in place. So you need to remove the catheter. And they typically don't leak when they are sitting or lying down. So you need to make the patient stand. So any woman who's not leaking needs to stand up. You need to remove the urethral catheter and measure from the abdominal pressure channel. But you can't straight away remove the urethral catheter because then you would miss a finding called cough-associated detrusor overactivity, which I'll show subsequently. So you can see here in this patient, the route of recording from the abdominal channel. The method of recording is a visual leak demonstration. At what fill have you done it? 215 ml. What's the position of the patient? She's standing up. What's the catheter size or lack of a catheter you need to record because the catheter can obstruct the leak. And what's the baseline used? This has to be the absolute zero and the transducer should be 0 to the atmosphere. And that gives you the abdominal leak point pressure. So take a look at this. Patient has had a stress test. That's a phasic contraction here. And then when you do a stress test, you find that there's no detrusor contraction. Remove the catheter, the patient leaks here. So this patient has urodynamic stress incontinence with an abdominal leak point pressure about 110. The flaw here is that this patient has not had a graded cough. So if you don't have a graded cough, it's difficult to tell for sure, would she have leaked on 80 centimeters? Would she have leaked on 60? Maybe it's done in a different cycle, but at least in the given cycle, you can't tell for sure. So unless you have spikes which are lower than this, and some patients find it difficult to do a graded cough. So they need to cough at 50, 60, 80, 90, and then see at which is the least pressure at which she leaks. But if all the coughs are 110, you can't really tell whether her abdominal leak point pressure is truly 110. It could even be 60 for all you care. Right. So what are the criteria for defining ISD? Abdominal leak point pressure less than 60 is severe ISD, or a maximal urethral closure pressure, which we are not going into today for UPP. That's if it's less than 20. And a clinical diagnosis of ISD is by the empty bladder supine stress test, where you ask the patient to pass urine and then ask her to cough. And if you see a trickle of urine happening, that is also a method of making a clinical diagnosis of ISD. Each of these three things yield three different pieces of information, and they probably do not define the same patient cohort. But they are all three methods of defining what possibly is a more severe form of incontinence. The next finding that you could get is what's called cough-associated detrusor overactivity. And this is a situation where the patient coughs and induces a phasic contraction. So this is the P vesicle channel. You can see when the patient coughs, you have these two spikes, but just when the patient coughs, that induces a phasic contraction. And how do you know it's a phasic contraction? You don't see it on the abdomen channel. So on the abdomen channel, you see the cough spikes, but no phasic contraction. So this is a cough-associated detrusor overactivity called Caddo. Now you can get leakage with a Caddo, and when the leakage happens, that's called Caddo Incontinence, and that can take 4 different forms. You can have leakage which happens with a phasic contraction. It can happen with the cough spike. It can happen with both of them, or can happen with neither. So these are methods. This is a system by which you can actually classify something that we published 2 years ago, the type of cough-associated detrusor activity to give a greater precision in your description of the patient's problem. Here you can see a type 2 Caddo, where the patient has Caddo, but leaks only with the cough spike, not with the phasic contraction. And this is a type 3 Caddo, where the patient leaks both with the cough spike as well as with the phasic contraction. Let's look at voiding Luts in women now. And voiding Luts can be because of an underactive detrusor, dysfunctional voiding, primary bladder neck obstruction, bladder outlet obstruction secondary to prolapse, or an anatomical stricture. Sometimes you could have unrecognized neurogenic dysfunction or a large urethral diverticulum or iatrogenic obstruction following stress incontinence surgery. Take a look at this trace now. And here you can see that this part is storage where the bladder has been filled. P-det is close to 0. So this is normal. There are no phasic contractions. Compliance is fine. When this patient tries to pass urine, there's a very slow flow and there's a very low pressure detrusor contraction supported by a lot of abdominal straining. This patient has an underactive detrusor, despite the fact that the patient is emptied well. So there's low post-void residual, but this is an underactive detrusor. Whatever coughs, the spikes you see in the EMG activity, these are invalid when the patient is having abdominal strain, because abdominal strain can induce spikes in the EMG. So you can't interpret that as dyssynergia. Take a look at this woman now, who's 52 years old, has voiding difficulty, which is refractory. She's got a high pressure and a slow flow. The sphincter EMG becomes silent when she passes urine. You can do a flow EMG and demonstrate that the EMG is silent when she is passing urine with no tubes in the urethra to cause a discomfort, because we know discomfort of urethral catheter can also cause EMG activity. And in a voiding phase of an MCUG, this is more than 2 years ago now, we do videos for these patients. You can see that there's no dilatation of the proximal urethra. This woman has a primary bladder neck obstruction, and an incision takes care of her problem. She passes urine freely at the end of an incision. So not a common diagnosis, but if you make up this diagnosis, a one-step treatment can take care of this. The next cause of voiding dysfunction. This is a woman who passes again with a relatively slow flow. So this part is the storage phase. This is the voiding phase, a relatively slow flow, a relatively higher voiding pressure. And we'll come to the numerical values in a moment, but relatively higher pressure. So she appears to be obstructed, especially if she's symptomatic for it. And this is a video trace. And you can see on the video trace that when she's passing urine, I'll just come to that point. Take a look what happens. You can see that there's a gross dilatation of the proximal urethra. So you can see here the urethra is dilated, high pressure, slow flow. This is a dyssynergic striated sphincter activity. This kind of a dyssynergic striated sphincter activity, if it happens in the absence of a neurological condition, gets the label of a dysfunctional void. So this is a woman with a normal neurological assessment. She has dysfunctional voiding in coordination of the striated sphincter, high pressure, slow flow, dilated proximal urethra, a classical case of dysfunctional void. Now, female bladder outlet obstruction has long been an issue, and it's been an issue in making a diagnosis for us. And for many, many years, we've had a lot of problems in trying to identify which woman is obstructed, and even more difficult, which woman is having an underactive detrusor. And the reason why there's been so much of difficulty with women as compared to men is, in men, you have a reliable model of obstruction in the form of prostatic obstruction, which you can operate and correct, and then you can see what happened. But you don't have that kind of a reliable model of obstruction in a woman where you can actually see what happened, what's there before, what's there after, and then you can compare and tell who's obstructed and who's underactive. So over the years, there are several people who've come out with criteria for defining bladder outlet obstruction in women. So the Blevas-Grouts criteria, for instance, pressures above 25 centimeters with a flow less than 12, retention despite a PDAT Q max of more than 20, imaging-based diagnosis in women with a history of voiding difficulty. That means regardless of the pressure, looking at the imaging findings to see whether you found a dilatation during the time of voiding in the outlet. And then what now seems to be more of a consensus around the Solomon-Greenville nomogram. So there've been nomograms before, but this one has more traction of late. This nomogram you're seeing to the right is the Solomon-Greenville nomogram. And what you see in this is, this side is the PDAT Qmax, this axis is the Qmax, and this tells you the probability of finding obstruction. So a patient here in the red zone has a probability of obstruction of 0.9 or 0.8, depending on which part and so on. Now, if the bladder outlet obstruction index defined as PDAT Qmax minus 2.2 into the Qmax is less than 0, your probability of obstruction is less than 10%. If that index is more than 5, the likelihood of obstruction is about 50%. And if it's more than 18, it's more than 90% chance that the woman is obstructed. This doesn't tell you whether she's also underactive. And many of these, so a woman who voids at 26 centimeters of water with 10 ml per second flow is obstructed, but she's also underactive because the bladder contractility is not good. So this tells you obstruction. But we still have absolutely no ways no consensus on how to define underactivity in women. What about pelvic organ prolapse and lower tract symptoms? This is a common finding in women. Always evaluate women with pelvic organ prolapse, both with the prolapse out and the prolapse in. Typically, you need to have a prolapse beyond the introitus to have a problem with voiding related to the prolapse. And let's take a look at this woman who is 65 years old, has a poor voiding. You can see here, she's generating a fairly high pressure contraction, but not voiding well. This is without a pessary. You put a pessary in, and in the same woman, you can see the voiding normalizes immediately. And this gives you confidence that if you operate this woman for her prolapse, she's likely to have a resolution of her voiding difficulty. The converse is not always true. So you could have women in whom you do all these maneuvers and they're not passing well, but when you correct the prolapse, they're able to pass reasonably well. But if you find this finding, what I've shown you here, you can be confident the patient will be okay. But the other way around is not always true. The other thing you are looking for in patients with prolapse is occult stress incontinence. And you want to reduce the prolapse completely by one of the 5 or 6 methods that are there to reduce it, and see whether the woman has occult stress incontinence or not. And the tracing that I showed you would remain the same. So I'm not going back into it because this is not so much of theory in this class. It's more of looking at traces. So the gynecology residents, if you are a few of them here for this class, could shut down and leave the meeting if you would like to. If you'd like to stay back, then there's a last section on neurogenic which might be of some interest to you. But otherwise, thank you so much for attending. Now, the next section would be on male lower tract symptoms. And we are going to look at prostatic obstruction, the underactive detrusor, and dysfunctional void. Take a look at this patient who has normal storage, high pressure, slow flow, and what looks like a patient who has dyssynergic voiding. Now, this looks to be a dysfunctional void if the patient does not have a neurological problem to explain it. This is normal compliance, as you can see, high pressure, slow flow. But let's take a look at the video of this patient. And I'll show you how the EMG is not really reliable. So let's come here and look here that there's a very high pressure, very slow flow, but you can see that the prostatic urethra and bladder neck is completely shut here, not opening at all. So you could have an EMG which is completely misleading. And this patient does not have dyssynergia. This patient underwent a bladder neck incision and is perfectly fine. So you can see here this patient, that the video is a better method to assess for dyssynergia than EMG. EMG can fire when it becomes wet, for instance. And there are many other things, discomfort and so on. Many things can cause the EMG to fire and mislead you. So the final diagnosis here is primary bladder neck obstruction. Take a look at this patient, another male. This is a young male, 25, 23 years old, storage, low pressures, normal compliance, no phasic contractions, normal capacity, normal sensations. When this patient voids, very poor flow and a low pressure contraction. So this is a patient who has an underactive detrusor. Let's look at the video of this patient and see whether we find something else in the video. Let's go to the place where the patient has voided urine and take a look what's happening. Vivek, what's that? So that's a dysfunctional void. You can see the proximal urethra dilating as this patient is passing. Sorry. Oops. Let's go back here. So you can see here the proximal urethra grossly dilated. Okay. Grossly dilated. So doing this maneuver has given us now an additional avenue for managing this patient. So we know this patient is underactive. You can't do anything about the underactivity, but there are several things you can do about the dysfunctionality. So you now have an additional method of managing this patient because you can address the dysfunctional void to improve the patient's voiding. So you can see here that sometimes it can help. And here you can see some amount of EMG activity giving you a clue. But as I said, EMG is not very reliable. If you scale this to 100, you'd probably find the EMG spike much more. This is scaled to 500. Scale it to 100, you'd find it spiking much more. And that would give you the clue that this patient actually has a dysfunctional void. So take a look at this third study in a male. Storage, you have phasic contractions. Some of these are progressing beyond the end of filling, but the patient has been given a command to void somewhere here. So these are all phasic contractions. But ultimately, this patient voids after another round of filling, and there's a very high pressure and a slow flow. So this patient has bladder outlet obstruction. There are ICS nomograms to define the degree of whether a patient is a male is obstructed or not, and these are based on benign prostatic obstruction. The bladder outlet obstruction index is actually an ICS nomogram, but the bladder contractility index is not strictly speaking, an ICS nomogram, but a lot of us have actually thought that both are ICS. They're not truly ICS. ICS never endorsed it, but it's more or less de facto become the ICS contractility nomogram as well. And you have a combined graph nomogram for both together. And you also have other nomograms like the Schaefer's nomogram. You have a green zone 0, 1, 2 where the patient is not 1 not obstructed, 2 where it's equivocal, and 3, 4, 5, 6 where the patient is obstructed. There were additions made to the Schaefer nomogram where you have the weak and very weak detrusor based on which part of the left lower corner the patient is in. So if the patient is here, the patient is very weak. On this axis you have flow, on this axis you have P-det. So that's another method of looking at bladder outlet obstruction in men. Let me skip all this for want of time. Now let me show another curve, and maybe I'll ask Suraj this time. Suraj, what does this test show?
There is a very poor flow with a very high detrusor pressure, which are noted. It is reflected on the vesical pressure, but in the only the flow part that
so this patient actually had a passable stricture. So the moment you put tubes in, there's no space and the patient appears to be obstructed. And actually what happened, this is a post-test flow, because obviously if this patient had a flow like this, he wouldn't have had a urodynamics in the first place. So this patient, there was some difficulty in putting the catheters. My technician actually negotiated and put the catheters in, but he had a doubt and he did a post-test flow, and the post-test flow is excellent. And this is an unusual situation where you actually have a therapeutic urodynamics where the patient's problem apparently gets solved. Now, what are the indications for urodynamics before prostatic surgery? The young and the old, less than 80, more than 80 or less than 50, patients who have very large post-void residuals, patients who have a high flow obstruction, flow rates above 10 ml per second, but dominant voiding symptoms, patients who can't produce a uroflow of 150 milliliters in a uroflow test, individual patients prior to surgery in whom for either the patient's questions or your own doubts, you deem that more information is necessary. Dominant storage symptoms with a low PVR if you're planning for surgery. Patients with Parkinsonism and associated conditions to see for, let's say, multisystem atrophy, Parkinson plus-like conditions, or in high-risk interventions where you want to be sure before you do an invasive high-risk procedure that the patient will actually benefit from it. You can see that the patients who are at the youngest age group, and this is a large study, almost 1,600 patients from our own database over 8 years, you can see that the youngest age group of patients actually are the least likely to be obstructed. So this is not necessarily, and they actually had the lowest contractility indices, but that's not a reflection of what happens in the general population. It's a reflection of the kind of patients who come to us in this age group and require a urodynamics. And you can see here, hence these patients, you would never ever think of doing surgical procedures without a urodynamics evaluation to assess what their problems are. We'll at the final section, we look at urodynamics for neurogenic lower tract dysfunction. And then we need to identify a few key concepts here. Now, again, this third line is the P-det line. And you can see as this patient's bladder is being filled, there's a progressive rise in pressure. So this patient has a poor compliance. At some stage, when you keep filling the bladder, fluid starts leaking by the side of the catheter. And the point at which that happens is called the Detrusor leak point pressure. And the volume at which it happens is called the Detrusor leak point volume. Both these are important because you could have a high Detrusor leak point pressure happening at a very large Detrusor leak point volume, which might not be clinically relevant. And you could have somebody in whom the pressures are relatively lower, but it happens at a very low Detrusor leak point volume, and it may be highly relevant. And I'll show that in a subsequent graph. So take a look at these two patients. These are two, this is from the Indian Journal of Urology in 2017, we published. This is a child, it could be an adult as well, in whom the pressure goes up rapidly and stays around this level, maybe around 30 centimeters of water, right from 75 ml onwards. And this is a second patient whom the pressures are low up till 300, and then it goes up rapidly and goes very high. And this patient could have a Detrusor leak point pressure of 50, and this patient could have a Detrusor leak point pressure of 30. To this, you need to add the average CIC volumes in these two patients. So if this patient's average CIC volume is 200 and this patient's average CIC volume is 250, you can see that this patient at 250 ml typical volumes has safe pressures, and this patient at 200 ml average CIC volumes has unsafe pressures. So paradoxically, this patient with a high detrusor leak point pressure is safe, and this patient with a lower detrusor leak point pressure is not safe. The other important concept is detrusor, neurogenic detrusor overactivity, and the Endo leak point pressure. This has been defined more recently. So you can see here, as you fill the bladder, you get phasic contractions, and you can get a leak. This incontinence. The lowest detrusor pressure rise with detrusor overactivity at which urine leak occurs in the absence of an involuntary, in the absence of increased abdominal pressure is the Endo leak point pressure. And it should be absence of a voluntary, it's not a voluntary detrusor contraction, it's an involuntary detrusor contraction. So you can see here, that could be the Endo leak point pressure, but it's not. Why? Because you can see the lowest one is this one. So that's the Endo leak point pressure, 48 centimeters of water. You don't have very good outcome data of patient outcomes based on Endo leak point pressure. So most of the outcome data is based on either end fill pressures or the detrusor leak point pressure, but not on the Endo leak point pressure. And there are issues with this particular entity, but since it's now been defined as residents and as trainees, you must know about it because you might get asked. So take a look at this patient who has an injury in D11 to D12. There are no changes in the upper tracts, no recurrent UTIs, no stone formation. This patient has phasic contractions, is able to perform CIC, that's a P vesicle, P abdomen, P red channel. There's a reduced capacity about 200 ml. There are phasic contractions. In this context is NDO. The end fill pressure is about 20 centimeters of water, which at 200 ml is high. So this patient has less compliance. And when the patient tries to pass urine, there's no volitional contraction seen at all. So this patient has neurogenic detrusor overactivity with acontractility. However, in the same patient, you can get some additional information again by doing a video. And you can see here that during these phasic contractions, there is a substantial dilatation of the prostatic urethra. So if this patient is using these phasic contractions to void, although this is not a volitional contraction, if the patient is using it to void, this would still be a detrusor sphincter dyssynergia, which is why you can make a diagnosis of DSD based on storage phase pressures also, provided that those are the pressures with which the patient is habitually or typically voiding at home. So this patient has detrusor Endo with DSD. You may say this is not a volitional void. How can we call it dyssynergia? Because this patient not voiding, and dyssynergia is a voiding phase finding. But because this patient uses these phasic contractions to void, hence, despite the fact that it's involuntary during storage, this is DSD. Take a look at another patient, or maybe I can show this to you. A 31-year-old male who had anorectal malformation, denies major voiding difficulty, has 1 to 2 episodes of febrile UTI in a year, is constipated but able to manage, ambulatory, normal upper limb function, keen intellect, and that's his tracing. And now let me ask Suraj, is this patient having a safe storage in his bladder? Is this patient safe?
The detrusor pressures are quite low, sir. The complex looks okay, and there is no leak noted during the filling phase, and he is able to around 320. It looks like a safe bladder. It is a safe.
Okay, so fair enough. Based on what we are seeing here, the patient has normal capacity, normal compliance, no NDO. There's some spontaneous rectal activity. The end fill pressure is about 10. That's the place where the patient was given permission to void. The patient is acontractile, no residue, void by abdominal strain, apparently looks fine. Okay. And the patient may ask you, is spontaneous voiding okay? He's able to strain with his abdomen and empty his bladder. There's no residual urine. What would your answer be? Yes or no?
Like, he has to have a detrusor pressure which is reflected on the P vesicle pressure, but he is using abdominal straining to void.
Okay, so the correct answer, Suraj, is that the decision of whether the patient can be allowed to void spontaneously or not, or for that matter, whether this patient has a safe urodynamics or lower tract or not, I have not given you enough information. The amount of information you have from this trace is not enough. So the urodynamics trace can tell you that a patient is not safe, but it can't tell you that the patient is safe. So if you find unsafe findings, the patient is unsafe. But just the fact that the traces look fine doesn't mean that the patient is safe. Okay. Now let's take a look. This patient actually has a creatinine of 5. There's bilateral hydronephrosis with hydroureter. And let's take a look at the video of this patient. There's gross bilateral reflux. Can you see the reflux into the kidney? On both sides. Large volume. So what appears to be good capacity is actually half in the upper tracts. What appears to be good compliance is because there's a pressure vent. And when this pressure patient voids by abdominal strain, there's a huge dilatation of the prostatic urethra. So the pelvic floor is dyssynergic when the patient tries to void by abdominal strain, further causing reflux into the upper tracts. So what looks like a safe bladder is not a safe bladder. So you can decide lack of safety from the urodynamics, but not make a diagnosis of safety just on the urodynamics. But it's an important component of making a diagnosis of safety. So if everything else was perfect, then this could have been a safe patient in whom you could have said, okay, you could have told the patient, okay, it seems to be okay to void. But given all the other findings, this is not safe. And you can see how the patient is having a creatinine of 5. So crucial lessons are patients with high risk neurological diagnosis must have urodynamics as one thing. This patient didn't have it for 31 years. Urodynamics must include or be combined with imaging. So if you don't do video, you should have an MCUG. So a good intuitive combination of MCUG with the UDS gives all the information or most of the information, and you should be fine. As long as you recognize the need for imaging, you'll be okay. Ideally video, but otherwise VCUG with UDS is an acceptable alternative by all guidelines. In fact, most of the international centers also don't do video. Ability to void is not important in this setting. It's the safety which is important. And ability to hold is not important in this setting. Again, the safety which is important. Right. So we spoke a little bit about DSD, and maybe I'll just skip a little and go further ahead for lack of time. Okay. Now, what are some of the conditions associated with DSD? A spinal cord injury, especially cervical, a vast majority, overwhelming majority of patients have DSD. Multiple sclerosis, about a third of patients who undergo urodynamics will have DSD. So not all patients, not 35% of all MS, 35% of MS patients undergoing a urodynamics will have DSD. Transverse myelitis patients, open spinal dysraphism up to 50% of myelomeningocele, and multisystem atrophy. So these are some of the situations where you get DSD. And DSD can be a marker for a high risk situation, especially if the patient has been trying to void spontaneously. Some related conditions, you could get pseudo dyssynergia because of voluntary contraction of the striated sphincter in CVA patients, cerebrovascular accident patients during phasic contractions. This can happen in a substantial proportion of CVA patients and also result in some element of voiding dysfunction. It could also be a response to pain or during abdominal straining, as we just saw. You could get what appears to be dyssynergia, which is not dyssynergia. You could get bradykinesia, where there's a delayed relaxation of the striated sphincter in patients with Parkinsonism. And this is in contrast to the true detrusor sphincter dyssynergia that you get in multisystem atrophy. And dysfunctional void, which we mentioned earlier, where you have all the features of DSD, but there is no underlying neurological problem that we see. The ICS says that the flow should be intermittent and or fluctuating, but we have shown and reported that this is not necessarily so. To make a diagnosis of DSD, you could do it on the basis of EMG, MCUG, combined with your UDS, of course, of video urodynamics, or by urethral pressure profile. But you must recognize that just EMG is not always reliable. So it's always preferable, especially in a high risk situation, you must combine with an MCUG. So an MCUG is invariably available. Do the MCUG, do your conventional UDS, you get all the information. The EMG has been classified into 3. I won't go into details for the simple reason that this classification has never been shown to give any kind of clinical relevance to your condition. Some of the common errors in patients with neurogenic bladder, and I think this is one of my last slides, interpreting the urodynamics in isolation. So we just saw what happens in that patient when you interpret in isolation. What appears to be safe is a patient under creatinine of 5. So you need to look at clinical clues. You must not confuse capacity with safe storage. So patients may have good capacity bladders, but be unsafe. In fact, we recently reported in the Asian Journal of Urology 13 patients who had chronic kidney disease and had augmentation cystoplasty. The reporting was for something else, but 3 of those patients had normal capacity, but they were in chronic kidney disease stage 3 and 4. Failing to obtain both anatomic and functional evaluation when lower tract dysfunction is suspected. So you need to get both of these. If you don't have the anatomical evaluation and you just do the functional evaluation, you'll get caught on the wrong foot many a times. Misdiagnosing lower tract dysfunction in patients with functional changes secondary to disuse. So there are patients in whom, for instance, the bladder has not been used because, let's say, they had a catheter for last 6 months, or they have had a bad bladder, the urinary diversion. Many of those bladders are normal, but they may appear to be abnormal. So let's say a patient comes to you with chronic kidney disease for a pre-transplant assessment. You must ask the patient, is the patient oliguric or non-oliguric? And if the patient is oliguric, you have to be careful when you interpret the storage, because storage may appear to be abnormal when it's normal, but you also don't want to miss a patient who truly has an abnormal storage. And doing repeated cycles of testing can sometimes help. And missing the clues to lower tract dysfunction, which is there from head to toe. By head to toe, I mean from A to Z of your assessment, right from the way the patient walks into the OPD, the gait of the patient, to looking at the back of the patient, to looking at the length of the gluteal cleft, to looking at the plain X-ray findings. There's so many things you have to look at before make sure that you have not missed an underlying neurogenic condition. I think I will stop at this point and let me see whether there are any. There's some chat messages. Arun, are there any questions? Yes.
One question only, that he has asked for some numerical values. That's what I could figure out.
So numerical values are unfortunately not standardized for most of the things. The only numerical values that are reasonably standardized are the bladder outlet obstruction index and the bladder contractility index in a male. The rest are all really not very well standardized. And you don't have good consensus between different experts on what is right, what is wrong, or what is, what should be the right things. So even for things like compliance and all, there's no standard value. But wherever we have reasonable data, I have tried to give it to you. For instance, what should be the regular storage pressure? What should be the abdominal pressure at different positions of the body? What should be the pressure when you start off? And so on. So I've tried to give you where we have values, but we don't have too many values which are standardized.
Next question is asked on the Uroflow, intermittent spikes touching the baseline, maximum of 4 ml per second and minimum PVR.
Right. So what you are describing to me appears to be what has been often called the staccato flow, where the flow goes up, down, kind of thing. Now, to call it staccato, the difference from the height of the peak to the bottom should be at least the square root of the maximum flow rate. So if your flow rate, peak flow rate was 16, it should dip by at least 4 and go up before you call it a staccato. Now, if you get a staccato flow rate, then it could be for a wide variety of reasons. Patient is uncomfortable. Patient is in pain. A child whose legs are hanging in the air, not unsupported on the floor. Psychologically inhibited. There are 10 people peering and seeing the patient when the patient is trying to pass. Or truly dyssynergic activity, which could be neurologically neurogenic or could be non-neurogenic, in which case it gets labeled as a dysfunctional void. So all these can produce that intermittent flow. You could also get that staccato intermittent flow in patients who have an acontractile detrusor, where the voiding is happening just by abdominal strain. And you just get those peaks and rises. That usually what happens there with the abdominal strain void with an acontractile detrusor is that the flow typically goes back to 0. So you get the flow peak, goes back to 0, and with the next abdominal strain, it again happens. So usually the flow doesn't continue. It goes to 0 completely and then comes back again. But these are not 100% foolproof. So the pattern of Uroflow is not a good guide to the underlying abnormality. The other thing which I think I didn't mention about the acontractility was that if you get acontractility in your patient, be very careful. You have to correlate it clinically. For instance, let's say if somebody is doing my urodynamics and I don't like the face of the technician, I might decide not to cooperate with the technician and it looks like an acontractile bladder. Or we have what's called situational inability to void. Situational inability to void is where the patient otherwise is able to void, but you ask the patient to void during the test, the patient is not able to void. So those things you will get from a careful discussion with the patient. Sometimes you have to be very patient, send everybody outside, do multiple cycles. There was a doctor who came to us from a different city who had urodynamics done at 4 different centers. And we did 7 cycles of testing over 2 different days, including 2 video cycles, both of which he didn't void. He produced 1 volitional contraction out of those 4 urodynamic studies. And including my 7 cycles, he produced 1 volitional contraction of 70 centimeters of water without voiding. And on the basis of that, I did a BNI for him last week and he's voiding well now. So you have to be patient and identify when a patient has situational inability to void. Sorry. Okay, who else? So Sarika has a question.
Before Sarika, we have 2 more questions.
Oh, sorry, I didn't miss it.
Yeah, so this is
okay, right. EMG surface or needle. So by and large, across the world, almost everybody has moved to doing surface EMG. It's much more convenient. As it is, UDS is a very uncomfortable test for the patient. And putting needles into the perineum makes it far more uncomfortable. And I think that whatever extra you gain by trying to get signals directly from the urethral sphincter is lost because of the fact that there's so much more discomfort in doing the test. So I've done needle EMGs as a resident. We were lucky at Sanjay Gandhi Institute during my training period. We had all of this. And but I don't think any major centers do it anymore. And many of the findings, like what they report, for instance, on let's say for the so-called Fowler syndrome and so on, they have been disputed. So there are several issues with that. So anyway, to answer your question, I use the patch EMG rather than the needle electrode.
So next question is again the controversial issue of doing urodynamics before surgery for male rescue to BPH. Yeah.
Okay. So I think what's important is Galaxy A50, whoever you are, what's important is to identify which patient you should be doing a urodynamics. So there's a fairly large number of patients in whom you will be able to clinically judge that the patient is likely to improve. But even in those patients, there'll be a small proportion who don't, and hence your counseling must include that. But there are clinical clues. And if those clinical clues are there, then you are not justified in doing your TURP on the patient, even if you don't have a UDS in your own center. So let's say a patient has Parkinsonism. You should not be doing a TURP on that patient without a urodynamics along with imaging, either with an MCG or otherwise. Because Parkinsonism patients have a wide variety of reasons. Some of them have Parkinson plus, they have MSA, and they may have dyssynergy and so on. And if the patient has MSA, it's an absolute contraindication. Sometimes it's not picked up by the neurologist. It gets picked up by you. So I think there are some situations where you must, but you should be able to identify those red flags, pick them up and test. And these days, we in our own 2017-18 survey, we showed that 50% of the people, urologists have UDS access in their own center. So, and a large proportion of urologists actually have access to urodynamics somewhere. Almost everybody had access to urodynamics somewhere or the other when we did the survey. On about 470 people responded. So it should be possible to do it if you need it.
The next I come to Sarika's question. Again, the values given of Qmax of 10 ml per second and Qmax of 30.
Sarika, where are you? Where are you, Sarika? You got to answer that question yourself. So we don't really have good data on this. So if she's voiding with a Qmax of 10 with a pressure flow of 30, she is obstructed by most of the nomograms. Is she underactive? I'd say that she probably does have a component of underactivity also, because are you there?
Yes, sir. Yes, sir.
Yeah, so I would say based on this that she probably does have a component of underactivity also, because if she's clearly obstructed, because if she's voiding at 30 with a flow of 10, then as per all the nomograms, she's obstructed. But in the face of an obstruction, I would expect a normal Detrusor to be able to generate more contraction than this.
Yes, sir.
I would say she is underactive, but it's more a hunch because you don't have good data to define underactivity in women. What are your thoughts?
Sir, it's most confusing scenario every time I am facing. So somebody gave that 25 above is obstructed, but at that time flow is not good. So it's for me it's a doubtful scenario. Okay, it's underactive or over outlet obstruction.
Right. So these nomograms in women tell us where there might be obstruction, but those nomograms don't exclude the concomitant presence of underactivity.
Yes,
because in women, and there's a huge overlap, just like in men.
Yes, sir.
So unfortunately, we still have to wait to get a good model of obstruction to be able to define these things better.
Okay,
Dr. Sanjay, this question from Dr. Prakash Prabhu. Your take on external sphincterotomy in patients?
Yeah. I just got that chat box open with me. So Dr. Prakash Prabhu. So external sphincterotomy, I have done it for the very occasional patient, and I'll tell you what's my reluctance. The external sphincterotomy is typically renders the patient incontinent. So number one, never in a female patient. I've had one female patient in whom somebody did a sphincterotomy. For heaven's sake, never in a female patient. I had to put an autologous sling for her. So you do an external sphincterotomy only for a male patient. And this is a male patient who typically can't do CIC. So for patients who can't do CIC, typically they are quadriplegic, where you would do an external sphincterotomy to render them incontinent when they don't have a caregiver. And then they need to wear a condom device, a collection device, or a sheath on the penis so that urine collects into the container without any obstruction and makes the upper tract safe. Now, typically wearing a device, a sheath, external sheath, or a condom on the penis typically causes ulceration over the long term. And it's very difficult to ensure that you don't have a problem there. So I am very reluctant to do it, but I can tell you that there is another situation where you may think of doing it once in a while. I mean, if you are in that kind of a specialized unit, in the very select patient, you might think of doing an external sphincterotomy and putting an artificial sphincter. So that's one situation where you may think of doing it, but external sphincterotomies are not 100% effective. A fairly large proportion of patients require redo sphincterotomies. I'm forgetting the exact percentage, but I think it was somewhere to the extent of 70 to 80% in some series. So redo external sphincterotomy requirements are fairly high over time. The next question, there is no evidence for bethanical, is still widely prescribed. Your take? I don't prescribe it. No evidence, don't use it.
Dr. Venugopalan's question is, any good method to study bladder pressure in a patient with bilateral VUR?
Right. So in a patient with VUR, abnormal storage pressures are what you're looking for. And any degree of abnormality I would regard as abnormal if there is a high volume VUR. So if somebody has high volume VUR and the storage pressure, end fill pressures are 10, I would say that this patient is having a poor compliance. So that's the first thing. So there are 2-3 things to look at, what I normally see. Does the patient have storage symptoms? So if the patient has VUR, has storage symptoms, that is a clue that there's likely to be some problems. And there, especially, you get a 5, 7, 10 ml centimeter rise in pressure despite large volume reflux. I'd say this bladder is suspect. I would also look at the bladder morphology in such situations. What's the bladder wall thickness and so on. So these are some situations where I also look at those things. But otherwise, in isolation, you just can't look at the pressure. So abnormal pressure with VUR is clearly abnormal, and any rise you should take with suspicion. But normal pressures don't mean that the bladder is normal. So you would again look at all the other things before you put a label of normality to that bladder. You look, is the patient symptomatic? Does the patient have normal bladder wall thickness and so on? And if all those things are perfectly fine, then probably the patient is okay. And then if you're doing a video, you can look at the bladder pressures before the VUR happened. So sometimes if the pressures VUR happens, let's say halfway through filling, you can get to see what happened during that half filling, what happened to the pressures and what happened once the VUR started. So that may give you some clue as to what's happening in the bladder.
The next question is from Dr. Keshav, urethral pressure profile.
Right.
So take on that.
Right. So the only situation where we now are offering UPP to our patients is the odd patient in whom there is acontractility, where I suspect that this acontractility might be a reflexic acontractility because of a hyperactive sphincter. Now, this is not a common entity. this is what is the underlying premise, let's say, of a Fowler syndrome. So if you have, let's say, a 30 or 25-year-old woman who inexplicably is acontractile, that kind of a patient, I would do a UPP to see whether they have high resting pressures. I didn't bring that here. This is already getting a 1 hour plus program. So I didn't bring UPP, those things here, but we do UPP in those situations. And now we are often doing all the three things, the regular urodynamics, doing video and UPP in some of these patients, try and understand what's happening. So sometimes that can be a clue. But even if you have not done a UPP, ultimately when you do that UPP, that may give you some clue that pelvic floor relaxation training, etc., can help. But some of the other things, let's say if you're planning to put a neuromodulation, or you're planning to, let's say, offer some of those things, so you could offer a neuromodulation even if the patient is truly acontractile. But you can define some subsets of patients of acontractility. I don't use UPP for any other thing. So I only use it for this one indication, where the patient is acontractile for no apparent reason, and if I suspect it's a hyperreflexic outlet. For all other things, I would use video. I find it much more reliable, or a UDS combined with a VCUGs should be fine.
Sanjay, next question is on, I think, drug management. How do you select, escalate your anti-muscarinic medications from obvious contraindications?
Okay. So the first comment to this is that this predates the urodynamics. I mean, in the sense, when you are on this question, your patient should not have had urodynamics, because for non-invasive therapies for OAB, you don't need to do urodynamics. So this is now a patient in whom there's clinical overactive bladder. You have started therapy. I would escalate based on the patient's response, based on an examination of the bladder diary, and based on a patient's desire for further escalation of therapy, regardless of what the bladder diary shows. So there are patients in whom the bladder diary still shows, let's say, 2 episodes of incontinence, but it's come down from 5. The patient is able to manage and may say, I don't want to further increase therapy, so I may not. And I would be let's say, I would be free to switch the patient to mirabegron, or add or put patient on mirabegron, especially in such situations, before escalating. So it's quite clear that adding mirabegron to anti-muscarinics is more effective than escalating the dose of anti-muscarinics with lesser side effects. So the randomized trials show that, and that's what our own guidelines also, in the text part of the 2019 USI guidelines, this is mentioned, that you should consider combined therapy rather than escalating the anti-muscarinic.
So next question is on post-retropubic prostatectomy incontinence. I think, how do you manage? And probably because our focus is urodynamics, if you want to say anything, the role of urodynamics in the evaluation of these patients.
So very briefly, the initial management is all conservative. You want to make sure that the patient doesn't have a concomitant stricture, which is not uncommon in these patients when they don't heal well. With conservative, and I would not, in the first typically 6 months or so, I would not think of any surgical management. And patients who improve with conservative management tend to show a progressive improvement rather than a sudden improvement at 5 months. So they tend to show slow improvement over a period of time. Every passing week, 2 weeks, they say, I'm a bit better, and so on. And aggressive conservative management. Those who don't respond to that, then depending on what their requirements are, if they are high volume incontinence, profound incontinence, then a sphincter is the best way forward. If not, then some form of sling is fine. There's a good randomized trial reported recently with Paul Abrahams as the lead author, which you should look at in the European urology. So I'll just
final question.
When a person...
This is Professor Pereira from Sri Lanka. He has got, when a person have urgency and frequency with a stable detrusor and bladder volume, what will be the urodynamic explanation?
Okay, a very good question, Professor Pereira. So what we now recognize is that overactive bladder is chiefly an abnormality of the afferent system rather than the efferent mechanisms. So if I were to phrase it in a different way, patients with overactive bladder have abnormal signaling systems from the bladder mucosa and submucosal layers to the brain. So either the brain's perception is more for the same signal, or there is more signaling happening. So their perception is more, they're able to sense more, and they get an urge which is earlier and stronger than the average patient. A proportion of these patients have an efferent component to their problem, where you also find phasic contractions. But then there's a large proportion of people in whom there's no efferent component to it. So it's primarily an afferent component abnormality. And all the treatments that we do, whether it's antimuscarinics, botulinum toxin, whatever therapies we are giving, mirabegron, they're all essentially targeting the afferent mechanism, not the efferent mechanism. And that explains why you have such low retention rates in these patients when you treat them. So I'd say it's a continuum of the same process, except that some patients have an efferent component. There are also some studies, and this comes from Marcus Drake's group, where they have actually put a balloon into the bladder with multiple electrodes in the balloon. And they have shown that in patients in whom you do not get a phasic contraction, you get what's called micro motion within the bladder. So the bladder wall has micro motions in response to filling, which causes, and there's urgency, but there's no coordinated contraction to produce a phasic contraction on your electrodes, or your transducer doesn't record a pressure, but there's micro motion which is abnormal happening across the bladder. And that can be picked up by putting multiple electrodes over a balloon and putting it to the balloon and inflating the balloon. And that's what they did. And they called it micro motions in patients with OAB.
Yeah, sir. Now the last question is from Dr. Srikala. She wants to know that if patient is already having 10 milligram of solifenacin and 50 milligram mirabegron combination, but still not relieved with the symptoms, what are you going to do?
So all the randomized trials that we have so far, including that 12-arm randomized trial that Professor Abrams reported in European Urology, show that 50 milligrams of mirabegron and 5 milligrams of solifenacin is as effective as all the other combinations that you can choose. So as effective or more effective than 10 milligrams of solifenacin, as effective as 10 plus 50. So I would generally not give 10 plus 50. I'd stop at 5 plus 50. And if the patient still has urgency, I'd look for other reasons why it's happening. Some of those patients have, so let's say a small proportion have occult neurogenic problems, small proportion have bladder pain syndrome problems, small proportion have refractory urgency, in which case they need escalation to botulinum and things like that. So I'd re-examine the diagnosis and definitely look at the bladder diary.
Sir, two quick questions. The one is the urodynamic in children, difficulties and solution. Our topic was in adults, but there's a question.
Okay, so very briefly, couple of lines. So in children, there are some additional issues. In the very young child, you may find it difficult to get voiding phase information. But in the very young child, if you're at all doing the urodynamics, it's because your back is against the wall because the child has a potential high risk problem. And in those situations, storage is much more important because in a 24-hour period, we store urine for 23 hours and 50 minutes and pass urine for 10 minutes. What happens during storage has a much more profound impact on the kidneys than what happens during voiding. So you can get storage information even in a newborn. Most of the children, it's possible with an experienced team to be able to manage without anesthesia and so on, but you have to be patient with them. You have to give them the right environment to be able to get the information. But usually you can get information from them and you need to explain to them what you are doing. If you just catch them and try and thrust things here and there, push tubes, shove tubes, they are not going to cooperate with you. So explaining to them, doing them, taking the parents into confidence, spending a little time, making sure our hands are warm, you have to be patient and have the environment there in the UDS lab when it's done. These days it's easy. Earlier you needed to have a TV in front of them with cartoons. These days everybody has a phone. So you can give them a phone in which they can look at something which distracts them. Any role of vasopressin and in control of enuresis day and night? So I would only use vasopressin. So this question has a different answer for children and for adults. I assume this is children. I usually reserve vasopressin for situations where I have demonstrated nocturnal polyuria. So I would actually do a bladder diary, see whether the patient has nocturnal polyuria in a child before I put the patient in vasopressin. For adults, vasopressin is the last resort. So essentially what the guidelines tell us, do everything before you give the patient desmopressin. So if the patient has OAB symptoms, put the patient on OAB drugs. If the patient has voiding symptoms, put the patient on alpha blocker. If the patient has peripheral edema, tackle the peripheral edema. If the patient has obstructive sleep apnea, tackle that. Do everything else. And if everything else is okay, you don't find a solution. And if the patient doesn't have global polyuria, very important, otherwise your patient goes into hyponatremia, then you can put the patient on desmopressin with careful monitoring of serum sodium. I think that should be fine.
Yeah, that's fine, sir. Yeah. So overall, a very, very excellent learning session for all the regents, but as well as for the members who have logged in for this program. A very erudite and very informative. We started from the basics, coming to the situations, covering both male and female, covering non-neurogenic and neurogenic, and overall a great experience. And a very nice question asked and very quality answers given to all the questions. Excellent session. And with this, I hand over to Dr. Keshamurthy and Dr. Rajiv Sood for the closing remarks. And for the Radiant quiz is open, please, you can open the link and answer the quiz. Over to you, sir.
Thank you, Dr. Sanjay, for a wonderful class. It was very nice. I've sat through the whole session. It was very informative. And we had a lot of viewers from Sri Lanka and Bangladesh. Thanks to all the viewers from Bangladesh and Sri Lanka. And over to Dr. Rajiv for his closing remarks.
Okay, sir. This was a wonderful lecture as usual. Whenever Sanjay is taking a lecture, he is the master of the craft. And also, he is a very good teacher. We are thankful to him for giving his inputs for the residents and all of us in this exhaustive lecture, which has covered almost everything related to urodynamics in adult, including the artifacts, including the male-female situation. And this will go a long way for teaching purposes for the future also, because it is archived. I'm thankful to all the residents also for attention they have given, and they should participate now in questions, answers, and also for the competition. And thanks, Sanjay, once again. Dr. Arun Chawla, you want to say something?
No, sir. Thanks to Navneet, our support staff. Thanks to the postgraduates who volunteered to be there. Vivek, Suraj, Saurav. Yeah, thank you.
Thank you very much. Good night for today. And tomorrow we have another wonderful session in under Indian School of Urology. Thank you very much.
Thank you, Sanjay.
Good night. Bye.
Bye, sir. Good night, sir. Good night, everybody.
Thank you.